And then exactly how we would assess preparation quality, and again at the bottom line, how we might do better, because I think probably all of us have problems with colon preparation, and have frustrating cases that we wish we had had better prep. So this is what we really want. We want to be able to get to the cecum quickly, and we want to be able to see the appendix and the ileocecal valve. And that way we know we've completely inspected the whole of the colon. But of course, as you see, we've obviously picked a nice view with no stool or any effluent in the way. But one of the things that is part of what we call key performance indicators, you can see them there in light green, is the fact that bowel preparation is key to all the intubation rate, the withdrawal time, and the adenoma detection rate, all things which are absolutely essential for quality colonoscopy. And again, these are you can see the target there that's set by the UK in terms of adequate bowel preparation, and we'll come to what constitutes adequate bowel preparation. But it certainly isn't this. And again, from time to time, in fact, yesterday, about 3 days ago, I encountered a Parkinson's patient who swore that he had taken all his 4 liters of Go Lightly, and he looked like the picture on the right, which again was perhaps predictable, but nevertheless very disappointing. So does it make a difference? Well, there's no doubt that it does make a difference. It correlates with cecal intubation rate, both time to the cecum, which again is a surrogate for a complete colonoscopy, as well as withdrawal time. And obviously, withdrawal time will be lengthened, not because you're trying to inspect the colon, but because you're trying to remove the effluent and the stool so that you can inspect it properly. Again, there will be maybe procedural difficulties, and it may be very difficult to tackle polyps when you see a lot of stool around them, far less, so you might be able to detect them. And again, you're going to miss polyps because you're really not inspecting the whole surface area of the colon. And then the other problem is what to do with those patients who you have inadequate preparation. When do you need to reschedule them? And what are you going to do about preparation next time round? Because obviously you don't want 2 of the same. So the bottom line is that 90% goal that I showed you as what they consider to be the standard of practice in UK, sort of even now in 2022, as you can see from the references, about approximately 25% may be inadequately prepared. And so that's a lot of patients and a lot of wasted resources from an inadequate investigation. So one of the ways that you can get around this is by making sure that your patient is reminded of what's going on. And I will come back to this. But there's no doubt that if you do refresh the whole bowel preparation process, you will get improvement in the preparation that you see in front of you when you're confronted with the patient. So what are the desired characteristics of the preparations? You want them to empty the colon of fecal material. You want them to have no effect on the macroscopic appearance. Ideally, you want them to have a short period of ingestion and evacuation. Ideally, also minimal side effects, or at least side effects that are very manageable. You want a low risk of complications, and you want the medication to have a good compliance with the patient, which again is related to factors of side effects and period of ingestion. So that's what you sort of are trying to aim for. So I'd like to, Cheryl, to put up this poll just to get a feeling for how many in the audience do what in terms of preparation. And these are some of the names that we see in South Africa, but you can see exactly the ingredients. So if you're from different areas with different names, please just try and pick the one that you would use most frequently. So if you could run the poll, Cheryl.
We're running it.
Thank you very much. And if you could share the, yeah, I think if you could share the poll.
It's coming up.
Says you've stopped sharing. So what I've got in front of me is that clean prep 4 liters is the commonest prep that we've used, 45%. Then it's sodium sulfate or colo prep. Moviprep gets a small mention, 14%. And then there are a few individuals who are using magnesium citrate and picoprep. Nobody's using Senecod, which is perhaps a good thing. And some others are there. So that gives me a good idea that the sort of pegylated preparations are, the ethylene preparations are in control. If I could have the next slide. And you can stop sharing that poll and run the next poll.
Give me a sec.
That's good. And so it's a very simple one. In your practice, do you split the dosage of your preparation?
Okay, it's there.
Thank you. Okay, so it looks about, yeah, it's about 50-50. Well, a little bit more are splitting their preparation. And yeah, 40% are giving it all at one go. Thanks very much. I'm going to continue now. That's given me some good insight. I'm going to sort of try and address some of these questions with what I've got to show you. If you can share the poll results, that would be nice. And we can stop sharing them now. Yeah, we can see that clearly. We can stop sharing them now.
Done.
That's great.
Okay.
Yeah, thank you. If you could take the poll down.
It is done on my side.
Okay. So these are the agents that are available. There are quite a few pegylated varieties, and I'll talk to them a little bit. Some of them are flavored, some of them have got ascorbic acid, some of them have got electrolytes. So they're all a variety of them, and they go by different names. And usually they've got lightly in them somewhere. Lights means electrolytes are in them usually. Then there are the hyperosmolar ones, of which sodium sulfate is far and away the commonest. But there are others that are used, and I know for sure that some of them, like mannitol, are still used in certain situations in Nigeria. And then you have the stimulants, which again were quite popular when I was a surgeon. Magnesium citrate was used as a popular preparation. And then there's sodium picosulfate, which comes in a variety of different names. And in fact, some people are still using senna extracts or stimulant laxatives to prepare patients who are at high risk. And then we have the adjuncts of bisacal and metoclopramide. Metoclopramide obviously being used to prevent nausea. simethicone to produce bubbling. So they're not really part of the package to improve the cleansing, whereas bisacidol is again another laxative agent that's been incorporated in a variety of different cocktails. And in fact, all the PEGs have got some of these ingredients in them to some degree. So it's very important for you to know which one you've got and which things you would like in it. So these are the sort of hyperosmolar preparations. They tend to cause large electrolyte shifts. And even though you're taking a small amount, you have to drink a lot. Otherwise, you will get into trouble. And the side effects, they are nauseating. They cause vomiting and abdominal pain and bloating. And that's also a problem with some of the others, but perhaps to a lesser degree. And again, adverse events are high in the elderly, and particularly in those with renal and cardiac impairment. And one generally advises not to use this preparation in those category of patients if you do use it as your general preparation. Then there's the sort of the sodium picosulfate preparations, Picoprec and Picolax. Again, pico is a stimulant activated by colonic bacteria, and magnesium citrate, and to a lesser degree oxide, is actually a hyperosmotic purgative. Again, these are contraindicated in renal disease, and electrolyte disturbances are common. Then you've got the preparations that we have that are popularized in this country. There are others as well, but you have the 4-liter clean prep preparation and the Moviprep. Predominantly, the difference there is that there is ascorbic acid in the Moviprep, and the clean prep doesn't have that. So they're both come with electrolytes, and some of them come without electrolytes, depending on the preparation. But it's quite a large volume to drink, and even at 2 liters. And then there's the splitting of the preparation, whether it's PEG or sodium phosphate. It's quite difficult to say that this shouldn't be done, because the bottom line is that splitting the dose, whether it's PEG or sodium phosphate, increases this number of satisfactory preparations. Again, this study is old, but almost the recommendations from the ASGE and from the British Society of Gastroenterology and Europe all suggest that split dosing is absolutely essential. So it was interesting to see that just over half of those of you who are attending actually split the dose. There may be many reasons for that. Some of it is to do with how the patient gets to you, and when you're doing your colonoscopy, as to whether it's feasible to take the split preparation. You ideally should take it, and this is why it's important, because if you have a long time between the single dose strategy and the performance of the colonoscopy, you will get intestinal secretions, chyme and mucin, and they may be particularly troublesome in the right side of the colon, which again, if you're dealing with a Caucasian population, is where one's very interested in the serrated adenomas and the very flat adenomas, which can be easily missed in bad prep, but which still carry a risk of a missed cancer rate. So there is a thrust to make sure that the whole colon is clean. And I'll come back to this when we discuss how you should be assessing your quality of your preparation. And it is, again, it depends whether you're giving the patient propofol or whether you allow them to take some clear fluids before your colonoscopy procedure. But basically, you should start to take the second dose approximately 5 to 4 hours before your procedure, and you should try and take it in about 2 hours, so that it allows you 2 hours to be completely fasted and free from fluids. Again, depends on the volume you used to drink, how feasible that is in a relatively short time period, especially if you feel nauseous. So there's also a high acceptance and compliance with split dosing, and that's the real recommendation of the guidelines, not only in 2008, and those guidelines haven't changed in any way. So there's been a lot of attempts at refinement of what's going on with the preparation. So which preparation is best for cleansing? Well, to be honest, there's no real significant difference between the two main competitors. That's the PEG solutions and the sodium phosphate. It's about compliance and side effects and safety and adverse events. Again, with the PEG, especially with the 4 liters, then well, that is a problem to drink for many people who are elderly. They just can't get over some of the side effects. But then with the sodium preparations, again, the elderly have a hard time, because you're much more likely to give them a very serious adverse event if they can't keep up with the hydration fluids that are necessary when you use sodium sulfate. So these are the things that you should be thinking about, again, with your personal preference of which of these two. I think the other competitors are less good candidates, but if it's all that you have, it might be that you have to work with those compounds to try and optimize how you can minimize the side effects and still get good compliance. So sodium phosphate, it's sort of, there is a systemic absorption of the phosphate, and that's why you get into trouble with patients who have impaired renal function. And again, with all of them, because you're drinking a lot of fluids and the reabsorption mechanisms of your gut are disturbed, you may well get into fluid and electrolyte disturbance. So again, it's important in the elderly also to think about whether you should give them some fluids during your colonoscopy procedure if you think they're quite dehydrated or extremely thirsty when you see them. So just be aware that you should make some sort of assessment of that, particularly in the elderly. And then again, there is this story, I must admit I haven't been involved with patients prepared with sodium phosphate, that they can in fact get rectal and colonic aphthoid ulcers. PEG, generally speaking, they are rarer than with the stimulant and hyperosmolar laxatives. There is disruption in sodium balance. Again, vomiting and aspiration can be a problem, primarily because you've sort of got delayed gastric emptying and they just can't keep up with the volume of fluid that's required to be drunk to get effective preparation. And again, all of them, again, have this problem because of that. And it may be compounded by the fact that they are on medications which make their compensatory mechanisms impaired. Preventing adverse events, well, there's a lot about enhanced educational reinforcement. That's a big term for just saying you need to speak to the patient more frequently with more different methods to reinforce what you're trying to get across. Again, the hydration story is very good. And one of the particular problems, which I will mention again, is that inpatients are a risk factor for poor preparation. And it may be in those that you may have to resort to nasogastric delivery, depending on their comorbidities and their ability to tolerate it. But it may well be that that's the best way to do it. I know in our institution, we have a terrible problem with patients coming from non-GI wards for colonoscopy because the preparation is uniformly below standard. And then again, you may decide to admit for preparation, so that's not really a very popular option. but it may be an option for patients who have failed preparation before. So these are the risk factors for poor preparation, and you can add to the comorbidities there, the drugs, especially the opiates and some of the psychiatric drugs, which will definitely slow down your gut transit. And then, obviously, if you've had previous poor preparation, that's a risk factor for it happening again. I've mentioned inpatients. And again, chronic constipation is one of the things that should be a flag in terms of ensuring that they have the correct instructions and perhaps instituting some other measures that we'll talk about in a little minute. Difficult bowel cleansing. So stop fiber for 3 days. We'll come back to what we do routinely because I haven't really focused on diet. Stop high residue food for at least 5 days. Again, stay away from corn on the cob and peas and lentils and these other things which are terrible at clogging up your colonoscope, especially the little valve, and making life difficult. And then again, you can decide how many days you want clear liquids for, and you can actually give them double dose and try and split the second dose. Some people will again use combinations of stimulant laxatives and magnesium citrate, which, to be honest, has largely gone out of vogue. It's not the safest of preparations to use. So these are some strategies that you should be thinking about in patients who are extremely at risk. And obviously, you should be thinking about these in patients who have to have a repeat procedure because of inadequate preparation. So now I want to sort of ask you this question, and that is, do you routinely assess the quality of your bowel preparation? And maybe I can add to it that, do you actually state this in your report? So we're just going to run that poll. This is very encouraging from what I'm seeing here. And there's 52. There's another 18 of you could vote if it's at all possible. That would be nice. So if we could perhaps end the poll and share the results, and you can see it would seem that all of you record the degree of preparation, at least 80% of you. So only 18% are not. So if you could run the next, if you could stop sharing that one and run the next question in this poll. Yeah, these are some of the common scoring systems that you will see, and which ones you use. There's still a few don't knows. If the don't knows could, so it looks, yes, if you could end the poll and share the poll, please. And you can see that it looks like most of you are using the Boston preparation score, a few using Ottawa and Chicago, but 20% are not using, are not routinely assessing the quality of their preparation, other than curse at it when it's poor. Thank you. If we can stop sharing that one. And so I'm just going to say a little bit about these scoring systems. There is a sort of definition of the quantity of the quality of bowel preparation, and that is that you should see 95% of the mucosa, again, after removal of residual elements and fecal debris. So this is the Aronchik, which is the simplest of them. And again, the problem with all these scores, including the Boston, is that they are somewhat in the eye of the beholder. All these scales, to some extent, have been validated. And I'll tell you what the final sort of conclusion is regarding them. This is relatively straightforward to do. And when we categorize patients in the GI unit at Groote we have a category of poor proceeded and poor gave up. So we have a sort of criteria that also sets as to whether or not you think it's possible to keep going with the preparation. So that's the Aaron check, and you can see the scoring system is 5 to 1, with 1 being excellent. And then this is the Ottawa. Again, this is very similar in its principles, in that it is a score that also assesses the 3 segments, and they are the left colon, the transverse, and the right, and they're scored separately. And again, you can add to that score, which you see there, which again is the reverse of the other score, where excellent is 0. You again can see that all these things are somewhat subjective in how you would assess them. And that's part of the problem with these scoring systems. They are subjective, and when you try to validate them, you get a considerable degree of variation in particularly what constitutes fair to good. And this is the Boston. Again, if we look at it's relatively simple. It's 4 categories for each segment, and you add them up, and the maximum score is 9. And again, between 6 and 9 is considered adequate, and that's what's considered by the UK to be what they want to have 90% attained. They want 90% to be between 6 and 9. And this is what the Boston Bowel Preparation Score looks like in terms of examples. And obviously, you can see just exactly how it is graded, though I'm not too sure what the difference between poor and inadequate is. And this is their sort of documentation website that provided these pictures. But it's pretty clear what is excellent and what is good. So how about sort of what we can do to improve things? I'm sure most of those individuals who are doing regular colonoscopies, their system has written instructions. Some have educational booklets. Many of the top American and European sites will have visual aids and videos that explain not only the preparation, but they also explain in detail the colonoscopy preparation. And then there's increasing information, which I showed you some of earlier, from apps that have been developed from smartphones, and also other mechanisms through social media that you can use. Again, internet resources, there are lots of resources regarding colonoscopy prep, very sort of European and American in their outlook, but nevertheless are used extensively and accessed extensively by individuals undergoing colonoscopy in these areas. I just did want to say something about diet. It used to be traditional that clear liquid diets for the whole day before were essential, but there's little doubt that the evidence would suggest that you can have a low residue diet quite simply for that period of time. And again, you should get your dietitian to define what is the low residue diet for your individuals. The reason for going that way is that it's more tolerable to the individuals in terms of that. But these sort of recommendations were largely from professional bodies without very good evidence, from manufacturers of the agents that are used for preparing and cleansing the bowel. And even worse, they're based on what was used for traditional barium enema preparation. So there, I think, is more work that might be needed depending on which diet you come from, especially in low-risk patients, as to whether you need any specific dietary advice. But for just now, you can choose between clear liquids and a low-residue diet. And again, as I said, these showed, I think, pretty realistically that there isn't much difference. But again, there were some methodological problems with some of these trials. So I just wanted to show you, this is, you can see where it's from. It's from an American healthcare system. And again, depends how graphically you want to be with the whole process. But obviously, if you're using social media and video clips, you can be quite graphic with explaining the steps and exactly how to do it. But I like this sort of partitioned sort of thing that tells you it in a temporal situation exactly what you should be doing during the day. And then the split dose occurs on the next day. And it also gives you a graphic interface as to what you should expect your patient to see if he looks down the toilet. And you should encourage him to, or her, to look down the toilet to see exactly what color the effluent is, because it may also be possible when they reach your unit to actually give them another liter of prep. So these are, again, this is the example that I just showed you, just blowing up. And again, I think these visual reinforcements are something we should be considering doing if we're not doing them already. And this is one of the apps. This is a German app. I think it's German, but I might be wrong, which has been used. And again, the findings from this study were that it enhanced the degree of preparation. And if you look at the randomized controlled trial that I spoke about, then there's no doubt that even SMS messages will help you to improve that. So in conclusion, poor prep equals a poor job, and we don't really want to do a poor job. To start with, you need to really think about how you're counseling the patients, how good your written instructions are, and whether you should be embarking on social media to reinforce that. There's lots of ideas, and there's definitely a need for more QIPs on a practical basis, I would suggest, particularly in Africa. Patients with predictors of poor preparation should get more intensive education and probably get an aggressive preparation regimen. Sodium phosphate and magnesium citrate, avoid them in the elderly and those with renal disease. And far and away, it would seem that the best compliance is with 2-liter pegylated preparations. They're probably the safest. And if compliance is part of the equation, that's one of the best reasons for also using them. And again, if you split the dose, you should do that because it will give you a better overall cleansing of the whole colon. And I would suggest to you, the 20% of you who are not doing it, that you should document the cleansing quality using a standard system. And the Boston is the best of the bunch, I would say, and it's well validated in a variety of different settings. So I would suggest to you that it's a good system that you should be incorporating into your reports, and obviously gives you an objective, at least semi-objective measure of whether you should be undergoing more quality improvements to improve the standard of your cleansing. So on that note, I hope that's given you a practical insight into some of the vagaries of preparing the colon, and I hope it's been of some use to you. I'm happy to take any questions or queries.
Thanks very much, Sandie. It was excellent. Kind of stuff you don't get in any textbook. If I may, just some anecdotal comments regarding to an experience in a practice where we largely do screening endoscopy, screening colonoscopy. Very disconcerting for patients to do everything and then be told you know, when they come for their results, that the prep wasn't adequate or wasn't good, or so there are a couple of red flags. I mean, you mentioned patients with Parkinson's, which are clear. In hospital patients, no doubt, clearly, you know, have to be prepped very particularly. But patients who are obese, and particularly morbid obesity, and also patients who are diabetic, it's a red flag, and we give an extended bowel prep, which is just a homemade extension of giving the extra pica prep 2 nights before, and we find that that helps with this problem of inadequate bowel prep, you know, after colonoscopy. So if you do have an inadequate bowel prep, we're fortunate that we've got CT colonography available for use immediately, and I resort to that just to give me the extra security that I'm not missing something, and also will allow me to extend the period where I'm going to repeat the colonoscopy with, you know, an extended bowel prep. So and often they can fecally extract, so you get very good views, and it kind of completes your colonoscopy examination. But if you do find that the bowel prep is inadequate, when do you repeat it in patients who are undergoing screening colonoscopy?
So again, I think that the tendency again would be, why did they come for their screening colonoscopy? I don't mean to go in a different direction, but I think most of Europe has moved towards fit testing as a pre-qualifier for colonoscopy screening. And so I might, if I would certainly do it once more, and I would do it within, generally within a year, unless there were any symptom signs at all. I don't think you need to say to the patient, you should come back tomorrow. I think you should give them a breather and bring them back. So yeah, obviously, if the colon is prepped, you know, again, you're sending them for CT colonography because they are partially prepped. But I think you want to be sure that the next time that you use an extended prep, and that you reinforce that whole preparation process.
Yeah, so sure, these are patients who are over 45 and want their colons checked. I do the CT colonography to allow me the year, and I agree with you, that's what we tend to do. An extended bowel prep a year later, and it seems to be reassuring, and we haven't really picked up any interval cancers in that time, or polyps that are worrying.
Yes. I think obviously the finer arbiter is missed cancers, but that requires huge numbers to prove that a system is actually not missing cancers. It's very difficult for the individuals to sort of really sort of get caught up in that, unless you're working in a huge institution. I don't know if there's any, James, have you any pearls of wisdom from your many years wielding the colonoscope? Please unmute if you can. You should be able to unmute. Can't hear you, James. I'm not sure if you've managed to unmute.
Can you hear me now?
Indeed, we can. Nice to see you.
Thanks very much. Thanks, Sandie. Thanks for an excellent talk there. I've just been reclassified from elderly to ancient, and so I've some empathy for the large volumes of elderly people who are coming in for their endoscopy. And here it's a challenge for the booking staff or the nurses, because they're not internet savvy, etc., etc. And so really the prep, the responsibility of the prep becomes somebody else's. And I must say, I've tried to involve the nursing staff of the old age homes, going there and giving them talks or whatever is required, handing them the protocol and so on, so that they can take care of these elderly people, because they're such high-risk patients. And for them to come in for an incomplete examination, and then they don't get the reassurance that they have because their daughter has insisted that they've probably got cancer and they must go, and so on and so on. These are sort of minor issues, really, of whose responsibility is the examination. And at the end of the day, I just want to make a plea then that once you've examined the patient and you've done the examination, as Chris Castanedis has told us there, and that you then have to share with the patient the bad news that it hasn't gone so well, that is a problem. You've given wise counsel, come back in a year, and so on. Interval cancers, I suppose, do happen, but nevertheless, it's the subtleties that we are trying to define with quality colonoscopy, the flat lesions, the flat adenomas, the right-sided pathology, and so on. So it's a minefield. I don't have any wise words, but I just want to say that if the examination is done and the prep has not been complete, you absolutely have to make sure that your reporting is spot on, that there is a responsible follow-up in place, and so on, because you remain medical legally liable.
I have a question for those of you who are doing underwater colonoscopy, which is very vogue now, especially for the left side of the colon, and also seems to be very well tolerated. And obviously the Boston score is really one of the scores that means you should assess the colon on the way out when you've cleared the debris. You don't assess it on the way in. So does anybody have any feeling about how you can convert sort of fair to good by using...
I can just speak to that, Sandie, because yeah, I'm a great enthusiastic, I'm a submariner of note, if you like, simply because one can clear the water so quickly from the colon. So, I think it's made a huge difference. You must just make sure that you've got a very good pump, very good suction, and so on, and that you document the before and after. So if you can photographically document what it looked like before you washed and then after you've been there with your submarine, that also helps.
Yeah. It'd be interesting to hear from anybody else, if anybody else wants to raise a...
Sandie, there's a question from Tim Demare, but if I may make just one comment with the elderly. We insist that the elderly do not, well, the elderly can be defined by probably...
Watch what you say, Chris. Watch what you say.
I mean, we don't do screening colonoscopies over 75, but we often need to colonoscope patients over 75 who are symptomatic. And we insist that someone is with them, during the bowel prep or around the bathroom, yes, because there is a number of patients who undergo vasovagal attacks, on the toilet, getting up too quickly, blood pressure falls, and we've had examples of patients fracturing skulls, etc., on the toilet seat. So we're very vigilant with having patients accompany the elderly. The elderly are a very particular group which really need to be, as James says, looked after very carefully. But there's a question from Tim. An experience with small volume prep. They use small volume prep in kids with reasonable success.
So I'm not sure what you mean by small volume, but I think as far as I'm aware, 2 liters is considered small volume, and when you split it into 1 and 1, then I think that's probably where you're going to get. It probably amounts to a 3-liter prep, because you do have to drink a bit more than you do with the 4-liter prep. But I think it's the best, and especially also splitting it makes it more tolerable, I believe. So I think there's lots of good reasons for trying to fix that, and also maybe considering starting your colonoscopy list at 10 o'clock, which means that your patient can start to take their prep, at 5 o'clock in the morning, and still you're going to have a double prep, and do it that way. So run your list from 10 till 2. Rather than from 8 till 12 or whatever. So I think there's ways that you can improve that. I'm not sure. I mean, obviously in the state sector, we have problems because really we don't want individuals needing to go to the toilet on taxis and in the bus. So again, that's something that you have to consider when you're looking at protocols that involve split prep. And as you saw, there's a significant number who are not using split prep in the responses that we got.
Thanks, Sandie. I'm talking specifically about sodium picosulfate, which so I think for adults it's 3 sachets in 250 mils each. So it's a lower volume. So we tend to use it in children, obviously, because of the volume of fluid that they need to take in.
Yes.
Yeah, sorry, that was my
Yeah.
question.
No, I think there's still quite a few protagonists in certain countries for PicoPrep and PicoLax, and again, that's part of the problem. You know, and if they're truly stimulant laxatives, then obviously they don't quite carry the problem that the hyperosmolar laxatives like sodium sulfate have, that you have to drink, otherwise you get into trouble and you've got a big phosphate load. So I think there's every reason to think that you know, PicoPrep would be good in children. I have no experience that way.
Then there's a question from
I could perhaps just hang my head in shame there and say to him that the split prep, sometimes you split with some magnesium citrate on the first day and your cola prep on the second day, and the children find that more palatable because max citrate is not unpleasant if it's cold, and sipped with a straw, and they can even believe they're having some cool drink. So max citrate in a small volume in pediatric use is probably frowned upon now, but it can be useful, particularly if you've had difficult children who've had long periods of constipation or medications and so on and so on. So that is another way of splitting the prep.
Great, thank you.
And Sandie, another question from Wisdom regarding diabetics. Do we follow the same regimen? Well, yes, we do, except we give an extra boost 2 nights before in my practice. I don't know any other.
Yes, I think again, if you have any suggestion that they've got gastroparesis, that means probably the whole gut is slowing down. So I think, you know, individuals who've got symptoms of that, I'm not so sure. You know, again, obviously obesity goes with you know, diabetes to a greater extent, and metabolic syndrome, and I think those patients are at risk. So I think you do want to individualize what you do with the patient, and assess each one on their merits. And again, you've seen mag citrate. You know, I mean, if in patients with chronic constipation, you can give them a horsewhip with 20 Senecot tablets. They might not like the colic. They might never come back for another colonoscopy, but it will actually, you know, act as a double prep. So yeah, we used to liken Senecot to actually, you know, running the Derby. It's asking the colon to do so much in 2.5 miles. So it also gives you a very highly colored thing. But I think Senecot is not really top of the pops anymore. So we'll leave it in its moratorium. Christian, I see that you're all the way there from the Cameroon. Do you have anything to add? Please unmute and let us know.
Nothing special. We used to take only this polyethylene glycol.
Yeah.
Every gastroenterologist in Cameroon, and we have a lot of satisfaction with this preparation, so no problem.
Yeah, thank you very much. Nice to hear you. Anyway, I think I don't know if there's any further questions. I think hopefully you've got some insight and some. Oh, there's one from Sianda. Please unmute yourself and ideally unmute your camera and let us see you. Yeah.
Hi, Prof.
Hi.
Thank you for the great talk. In terms of just broadening the scope from outside diabetics, a lot of the patients are elderly and are taking opioids such as tramadol as well.
Yes.
Do you then change your prep for those patients? And then also in terms of the scoring systems, which one would you then recommend to use?
So I think the Boston scale is the most validated and the best to use, and you should be assessing not just the whole colon, but the segments of the colon. That's what you should be doing. I think you can. So I used to say that physicians know 20 causes in random order, but I'm sure there are 20 drugs that are very bad for colon prep. And again, you have to to know those drugs. I think the opiates are top of the pops. I think some of the psychiatric drugs are there too, and many of the elderly are on polypharmacy. So it's not just give the patient a leaflet and take the prep. This is this particular patient, and this patient's going to need this. And you've heard, from patients in old folks' homes, they're a nightmare. Again, and you need to take some. Otherwise, you're going to put the colonoscope in and not get past the rectum, which is really not the object of the exercise at all. So I think you do have to individualize it, and the more comorbidities that the patient has, the more drugs that they're on, the more you have to think, I need more educational, more reinforcement, and a different strategy of what I'm going to use, or a double strategy of what I'm going to use. I hope that's as clear as I can make it, I think.
Yeah. Thank you, Prof.
Sandie, we've got a few minutes left, and Kay Colson's, published quite a lot with you on colonoscopy. Kay, do you have any comments?
Oh, she's there.
Yeah. Maybe hiding, but she's here. Caught red-handed.
She's in the middle. Do you think she's cooking the children's
No,
supper?
she's getting ready for the 6:30 about 10 virtual
CPD meeting. Yes.
Yeah. Okay.
Yeah, looks like we've drawn a blank there, but hopefully, thank you very much to all the individuals here, and thank you very much to the whole ECHO organization and ECHO India, who just continue to keep the platform working and doing all those things. Remember, this is recorded. If anybody wants to see it, it's available on the Gastro website. And I'd like to thank the ladies who are behind the scenes here, who organize everything and keep in touch with India. That's Karen and Cheryl. And thank you to everyone for participating. I think there were a few pearls of wisdom there that I was unaware of, and especially the pediatric side of it. And hope to see you next week, when I will be chairing a young lady who's very good at putting in duodenal stents and knows about the practicalities. So look forward to seeing you next week. And we're done for just now. Thank you very much.
Thanks, James, and thanks, Sandie. Nice to see you, James.
Very good, very much so. And you, Christian.
Yes, hello, Christian, our regular. Cheers.